Yes, so we'll be talking of carotid stenting and what are the rules which we should follow. We know that once carotid stenting, you may be symptomatic with a stroke, TIA, or you may not be symptomatic and had no previous episode, and you would be asymptomatic. Carotid stenting, carotid artery, luckily, can be very easily assessed and can be studied very easily with Doppler. So the initial comparison in 80s was between surgery and medical treatment for asymptomatic and symptomatic. And then there was this comparison between carotid artery surgery versus stenting for symptomatic and asymptomatic patients. The overall, there is a belief that the carotid artery stenting is done in asymptomatic stenosis in probably unindicated cases or not strongly indicated cases. I would strongly feel that the event that happens, the stroke, and the disability it leads to is so strong, so severe, that I would be all for carotid stenting if I was to get a carotid artery narrowing. So over the last about 20 to 30 or 40 years, we have seen so many important studies which have highlighted the usage of different techniques and taking us to safety. The important reason is you have a small embolization from the carotid, and it will definitely be producing symptom. So the risk of stroke is very important, and especially in somebody who is asymptomatic, the risk of stroke becomes very crucial. That somebody who is healthy has a carotid stenosis and you are doing a procedure and he lands in a stroke. 60 to 70% decline in the annual rates, irrespective of baseline stenosis severity, of any and ipsilateral stroke is seen, and this is probably because of very good medical treatment. And the medical treatment has clearly brought down. So, and the reduction is very similar to that observed in Act 1 and CREST after a successful carotid surgery or stenting. So obviously medical treatment also has a very important role to play, and this includes studies like Sparkle, which showed that medical treatment can bring down the stroke rate related to carotid artery stenosis. So this would obviously mean very aggressive treatment of hypertension, lipids, diabetes, and in general, all the vascular systems. Now, this is a case when you inject the left, you can see the right getting completely opacified. And the reason was the right was showing a total obstruction. So you can see the total obstruction in the right carotid. In addition, the vertebral origin and the right subclavian also is showing very important lesions. So the patient didn't have a stroke, possibly because of extensive collaterals coming from the right side. And this is where we have put a stent towards subclavian, stent towards vertebral, and a stent towards the right carotid, and thus stabilize this patient. So this is the final scene. This was to begin with, and this is how the stents have progressed. There is another case like this
Khanna.
where we can't see anything going to the right artery. Left is critically stenosed, and left was giving extensive collaterals to the right. So stenting to the left makes a lot of sense instead of struggling to get the right open. I would feel that the coronary techniques which we use for CTO don't hold true for carotid stenting, and one should not attempt opening up of the total occlusion. Now, what happens when you have bilateral stenosis? Like this was a right carotid which showed a critical stenosis, and here the stent is placed, and this is the post-stenting result. So many times we accept some degree of stenosis and not post-dilate with a balloon, possibly to avoid distal embolization. This lady had a very critical left stenosis, and so we fixed the right first, which improved collaterals to the left. And then we are now coming to the left, working on the left system. So this one actually needed a pre-dilatation for the distal protection device to go in. And then we could put in a stent to get this kind of results. So both carotid were stented. And the not so critical one was stented first, improving the collateral supply, and patient was brought back for the left, which was a very critical and possibly a thrombotic stenosis at a later date. Uh, Now, this is another lady who has a critical stenosis, as well as you can see calcification towards the end of the picture. And uh, and protection device is of course very important. So you bring whatever to the location, but have a protection device on the top, which fixes any possibility of distal embolization. And this is how the final result is achieved, with a good flow and fully open vessel at the site of stenting. What about both right as well as left, both carotid stenting? Of course, stands to reason that we don't do it together in one sitting. Let the critical one do first, take a little gap, and then bring the patient back to do the opposite side. Also, the balloon dilatation, once you're put in a stent, is also a very important issue, and so many times we don't dilate. Also, the lie of the innominate or the carotid artery, as it originates from the aorta, is very, very important, and very tortuous vessels. Like in this case, the wire is placed in the external carotid balloon support, and on that we advance the carotid, and then a critical lesion in the internal carotid origin is handled. So this is how the final stenting would look, and you have a well-placed stent at this location. So the access is very important. In this case, we had to first fix the iliac arteries and thus gain an access. So you may do temporary balloon, but I would feel the patient of this nature is bound to get symptomatic from legs too. So we fix the leg first and then bring them back for carotid narrowing. What about both right and left together? No. As we said earlier, they should be done at a separate stenting. Then this was another case who had everything blocked. The only access available was a right arm approach. And here we are with the right arm approach for right internal carotid stenosis. You can see acute vein from right to right carotid. And to advance this, we have placed a balloon inflated in the external. And on this, we have used a red rolling. So a small micro catheter, as you can see here, on which a thicker guide catheter is brought in. And this is the final stent placement before it is inflated or deployed. So this is a case I was doing in a workshop in Penang, and this patient had no access, only a right access, right arm access. And this is how the right arm access, the catheter is brought in, and it was made to look into the carotid. So right access can be suitably used for left carotid too. And then sometimes you have this bovine arch, as you can see here. Both the carotids, they originate as a single trunk, and you may have to sort of make some special efforts. Like in this case, you are just positioned at the tip. You bring in a slippery wire, and on that wire you can actually get in, and thus a critical lesion if the bovine arch was addressed. This was another lady who had only one vessel going to the brain, and that too had a critical stenosis. So this was a 32-year-old case of aortoarteritis. And by the time we waited for the ESR and other parameters to come down, this is what happened. The aorta is here, the innominate artery got completely closed off, and then we had to work through this totally occluded innominate artery. So you could see some contrast filling up here, better contrast filling up here, and finally you can see this artery is so crucial for this lady that it was supplying both sides and the vertebral system too. So this is how the event happened. We have stented 2 long stents into the right carotid, which was totally occluded, and this is supplying the both sides of the brain. So this is what happens in aortoarteritis many times, that very few collaterals, and once you open up, you would probably see many things happening. Tight lesion, by the time we took her up, total occlusion, 2 stents placed, and this right carotid is supplying both carotids on the right, both cerebral circulation, the right as well as left. Age becomes very important because the elderly, the patient, the brain is compromised. There could be comorbidities like cardiac and renal issues. And more importantly, the arch is very, very tortuous. Accept natural history to some extent and try and manage these elderly with medical treatment, unless, of course, the symptomatology is driving you to do this. So age is very important, but more elderly the patient, the more the reason to go. So, do I have any more time or shall I stop?
Well, I think we are a little bit behind with the time. So if
Okay.
there are any important points that you'd like to mention, yeah, please. Okay. Thank you very much, Dr. Hiremath, for this nice presentation. I think we need to leave the question to have a time, and let's proceed for the next. The next speaker is Dr. Michel Henry.